All right, so I'm recording. Let me go ahead and get to the page really quick. So this is video 2 in the 6-part video series on hemodynamics and circulatory shock. And in this video, we're going to be talking about hypovolemic shock. My name is Lexi Graham, and let's get started. So some common physical findings. That's where we're going to start with this. So after assessing the ABCs of the patient, which is airway, breathing, circulation, you can check for signs of shock. So do not rely on systolic blood pressure as the main indicator of shock. This practice results in delayed diagnosis. Compensatory mechanisms prevent a significant decrease in systolic blood pressure until the patient has lost 30% of blood volume. More attention should be paid to the pulse, respiratory rate, and skin perfusion. Also, patients taking beta blockers may not present with tachycardia, regardless of the degree of shock. So, classes of hemorrhage have been defined based on the percent of blood volume loss. Treatment should be aggressive and directed by response to therapy rather than the patient's initial classification. So, classes of hemorrhage, class 1 would be a loss of up to 15% of the body. 15% of the body's blood loss. So, in the absence of complications, only minimal tachycardia is seen. Usually, no changes in blood pressure, pulse pressure, or respiratory rate occur, and a delay of capillary refill longer than 3 seconds corresponds to a volume loss of approximately 10%. Class 2 hemorrhage is a loss of 15 to 30% of the blood volume. Clinical symptoms include tachycardia, tachypnea, decrease in pulse pressure, cool and clammy, delayed capillary refill, and slight anxiety. The decrease in pulse pressure is a result of increased catecholamine levels, which causes an increase in peripheral vascular resistance and a subsequent increase in diastolic blood pressure. Class 3 would be a loss of 30 to 40% of the body's blood volume. By this point, the patient usually has significant changes in mental status, such as confusion or agitation. In patients without other injuries or fluid losses, 30% to 40% is the smallest amount of blood loss that consistently causes decrease in systolic blood pressure. Most of these patients require blood transfusions, but the decision to administer blood should be based on the initial response to fluid. And then the fourth class hemorrhage is greater than 40%. So symptoms include the following, which would be marked tachycardia, decreased systolic blood pressure, narrowed pulse pressure, or immeasurable diastolic pressure. Markedly decreased or no urinary output, depressed mental status or loss of consciousness, and cold and pale skin. This amount of hemorrhage is immediately life-threatening, and you should probably get some blood for that patient. Next, we're going to talk about the chest, abdomen, thighs, and outside of the body, which are the 4 areas in which life-threatening hemorrhage can occur. A few things to note during the patient assessment. So first, you're going to start with the chest, and it should be auscultated for decreased breath sounds because life-threatening hemorrhage can occur from myocardial, vessel, or lung laceration. The abdomen should be examined for tenderness or distension, which may indicate intra-abdominal injury. The thighs should be checked for deformities or enlargement, signs of femoral fracture, and bleeding into the thigh. And the inpatient's entire body should then be checked for any other external bleeding. Causes could be of hemorrhagic shock are traumatic, vascular, GI, or pregnancy related. Next, we're going to talk about imaging. So imaging studies to help diagnose the patient or find out where the bleeding is coming from. So hypovolemic shock requires ultrasonographic examination in the ED if an abdominal aortic aneurysm is expected. If GI bleeding is suspected, a nasogastric tube should be placed and gastric lavage should be performed. An upright chest radiograph should be obtained if a perforated ulcer or Boerhaave syndrome is a possibility. Endoscopy can be performed to further delineate the source of bleeding. A pregnancy test should be performed in all female patients of childbearing age. So if the patient is pregnant and in shock, surgical consultation and the consideration of bedside pelvic ultrasonography should be immediately performed in the ED. Hypovolemic shock can be secondary to ectopic pregnancy, and it is very common. If thoracic dissection is suspected, because of the mechanism and initial chest radiograph findings, the workup may include a transesophageal echocardiography, an arterography, or CT scanning of the chest. If a traumatic abdominal injury is suspected, a focused abdominal sonography for trauma, which is FAST for short, ultrasound examination may be performed in a stable or unstable patient, and then CT scanning is typically performed in a stable patient. Hemodynamic monitoring, so you're going to use a Swan-Ganz catheter to monitor their hemodynamics. So all of these values right here, the CVP, PAP, PCWP, and cardiac output, these will all be decreased besides the systemic vascular resistance. That one will be increased. Medication options. So for this, you want anti-secretory agents, which means anti-secrete. These agents have vasoconstrictive properties and can reduce blood flow to portal systems. And these two include Zecnil and Sandostatin. You can also use vasopressin. This can be used for patients who have gastrointestinal bleeding. Associated with hypertension and arrhythmias should be a secondary measure. So you can also use lactated ringers to increase vascular blood volume as well. And then next we have ABG anomalies. So early on, the patient will have a respiratory alkalosis because of the patient having anxiety, they're hyperventilating and blowing off too much of their CO2. And then later on, it would be metabolic acidosis because the body is losing all of its nutrients, hence all the mass amount of blood loss. Mechanical ventilation options, plus maximizing the O2 delivery. High flow is what we want to give the patients and all patients, and to support them, support their ventilation and oxygenation. But if you are using the mechanical ventilation, you want low tidal volumes and minimal PEEP. So optional or optimal PEEP. Excessive positive pressure ventilation can be detrimental for a patient suffering from hypovolemic shock and should be avoided. So low tidal volumes, minimal PEEP. Volume control can help balance the blood gas, whereas if pressures get too high, pressure control, assist control can help keep the patient stable hemodynamically. Some concerns with positive pressure ventilation in hypovolemic shock would include the decreased cardiac output and decreased venous return. Since the patients will already have a decrease in both because of the excessive blood loss, adding more positive pressure may further impede on those great vessels, thus worsening the patient's condition. So if you have decreased blood volume, will equal decreased venous return, decreased stroke volume, decreased cardiac output, and then decreased tissue perfusion. And so in summary, just to summarize all this up, we talked about how the patient would present with the decreased breath sounds, tenderness or distension in the abdomen, look for deformities in the thighs, altered mental status, pale skin, decreased urinary output, delayed capillary refill, tachypnea, tachycardia. If they have a decrease in blood pressure, if they have that means they have a greater than 30% loss of blood volume. And then a narrowed pulse or anxiety. And then imaging we talked about. So options for that would be ultrasound, chest radiograph, CT, the transesophageal echocardiography, abdominal sonography, and then the FAST, which was the FAST abdominal sonography for trauma, the ultrasound for that. And then you can also do the aortography. We also talked about the hemodynamics, the CVP, PAP, PCWP, and the cardiac output will all be decreased while systemic vascular resistance will be increased. Along with the ABG anomalies, we also talked about those. You'll have the respiratory alkalosis early on, but the metabolic alkalosis later on with that. And then we talked about the meds. You want the anti-secretory meds, just to try to keep all the blood that's coming out to not come out. You can use the vasopressin and lactated ringers to increase that blood volume. And then we also talked about the mechanical ventilation options, which is low tidal volume, low PEEP. You do not want to keep increasing the pressures, impeding on those great vessels when this patient already has an immense amount of problems already. VCAC to balance the blood gas, PCAC to keep them hemodynamically stable, and just make sure you monitor that because there are concerns with cardiac output, decreased venous return, and all of that. So that is all we have for this video series on hypovolemic shock, and thank you for watching.